Good morning and welcome to our fourth meeting in 2013 of the Health and Sport Committee. And as usual at this point, can I remind anyone who has BlackBerry or any other mobile device to please turn it off, because it can sometimes interfere with our sound system. The first item on our agenda today is a roundtable evidence session as part of scoping exercise to help us develop a remit for the committee's inquiry into health inequalities. And as usual, when we do the round table, we introduce one another, which is helpful, and then we have a quick quiz to see how many names we can remember. But my name is Duncan McNeill. I'm the MSP for Greenock and Inverclyde and convener of the Health and Sport Committee.
Thank you, Duncan. My name's Carol Tannehill. I'm Director of the Glasgow Centre for Population Health, which is a research and development centre focused on developing evidence and providing leadership for action to tackle health inequalities.
Bob Doris, MSP for Glasgow, and I'm also Deputy Convener of the Health and Sport Committee.
I'm Graham Watt. I'm Professor of General Practice at Glasgow University.
Drew Smith, MSP for Glasgow.
I'm Sally McIntyre. I'm Director of the Institute of Health and Wellbeing at Glasgow University.
Mark MacDonald, MSP for North East Scotland.
I'm David Little. I'm here as a board member of the Poverty Alliance.
Gil Patterson, MSP for Clydebank and Mulgai.
I'm Erica Wimbush, Head of Evaluation at NHS Health Scotland.
Richard Simpson, MSP Mid Scotland and Fife.
My name is Jerry McCartney. I'm a consultant in public health and head of the Public Health Observatory team at NHS Health Scotland, which is part of the Scottish Public Health Observatory.
Aileen MacLeod, and I'm MSP for the South of Scotland.
Thanks, everyone. And all our excitement earlier, we've not got a first question. Would any of the committee members like to ask the first question to open this up? Or? Aileen, thank you.
Thanks very much, Convener, and thanks very much for everybody coming this morning to give evidence. We heard a few weeks ago from Sir Harry Burns, who's obviously their Chief Medical Officer, who said, this was on the 22nd of January, that inequalities in health are just a manifestation of inequality across the whole society. To target inequalities in health without trying to understand what the drivers are for adverse outcomes across all those domains is to miss the point. And he also said that it would be a mistake for any part of society to think that inequalities in health are just an issue for the health service. They are an issue for the whole society, just as inequalities in relation to offending work and so on are issues for the whole of society. And unless we understand that, we will carry on experiencing problems. And I just also wanted to take a quote from the paper that we received from Jerry McCartney as well, who said that given that income, wealth and power inequalities are the key determinants of health inequalities, it is unlikely that health inequalities will decline if substantial progress on reducing these economic and democratic inequalities is not achieved. So the first question I would just like to ask, just as a kind of general question, is to say what in your opinion would make the biggest difference or, you know, the most kind of positive impact on health inequalities in Scotland?
Well, I think what you've described is exactly that. So any set of policies or actions that can narrow these inequalities in income, power and wealth in society are the most likely to make that difference. And we've got good evidence to suggest that that's the case. If you look at inequalities time trends across the world, there's a couple of good studies from the UK and the USA which track inequalities in health from 1920 to the current day. And what you see is that these inequalities dramatically reduce between about 1920 and the mid-1970s, at a time when income inequalities, wealth inequalities, and inequalities in power, as would be measured by the rise of the welfare states in those countries, had declined. But then in both countries you saw that reverse as income inequalities rose, wealth inequalities rose, and such like. So we have fairly good evidence that income, power and wealth inequalities are what drives health inequalities.
Sally McIntyre.
I just wanted to say that I think the three key issues are employment, income and education. And I think it's really important that these policies to do with those would help reduce social inequalities in health and other things. So I think those are three key domains.
Anyone else? Agreed.
I think that Harry's saying that it's not going to be addressed satisfactorily if it's seen as a job for the NHS. I think there's a slight twist on that I'd like to make. I think health equality has been professionalised, and it's become something that rather a small number of people are involved in at the policy level and the delivery level. And I think that's a recipe for failure. It's either an issue that's addressed by everyone in the mainstream, or it's going to be a marginal, ineffective issue. So I think that's one aspect of the way in which the problem's not been effectively addressed. I think the other thing I'd like to say is that I would find it helpful to be looking at two questions. One is, what are the origins of inequalities, and therefore what are the policies to address that? That's trying to prevent them. It's trying to extend healthy life expectancy. There's another issue, which is what can the health service and other services do once health inequalities have arisen? And that's a very important part of the equation. It's clearly not going to do anything to address healthy life expectancy. But once healthy life expectancy has ended and people have acquired the conditions, usually several conditions, with which they're going to live the rest of their lives, we have a much clearer set of resources available to us to influence that than we have to address early origins, for example. So we shouldn't put all our eggs in one basket. The issues of, and Harry Burns quotes, the negative effect of a chaotic and adverse environment in the early years. Well, by analogy, a chaotic and adverse environment when you try to engage with the problems of multiple morbidity is a recipe for widening inequality in later years. And we need to look forwards as well as backwards. Looking backwards, we might ask ourselves how we got into the mess that we're in. But looking forwards to a population that's getting older, that's acquiring multiple morbidity, that's having to try to live well independently with its conditions, we need to be sure that public services are not widening inequality. There's recognition last time you met that many health improvement initiatives can have perverse effects where they're taken up and where they're not taken up. And one needs to extend that argument and recognise that the health service as a whole has the potential to achieve the same perverse effects unless we make it our business to identify them and address them.
Anyone else? To pick up, even I'm always going to give our panel of witnesses here the first say. So if there's anything that Professor Watt has said that provokes a comment, then please do. Professor.
Thank you. I'd like to pick up on the theme that Professor Watt introduced there about looking forwards as well as looking back. And I think that the evidence, as Jerry and Sally have said about the determinants of health inequalities, is now very strong. The challenge for us is thinking about what more Scotland can do to address those determinants. But I think it would be worth the committee also considering what the future determinants of health inequalities are going to be, and some of the trends that are emerging now that might be a cause of future health inequalities. I'm thinking, for example, about the move towards e-health and how digital exclusion might, in that regard, perpetuate health inequalities. I'm thinking about the changing nature of work, the evidence in and around work and health inequalities was developed at a time when employment was very different to how it is today. And if the committee wants to be thinking about what Scotland can do to help reduce health inequalities in the future, being concerned about the changing nature of work and the consequence of people being in and out of poor quality work on short-term contracts, and the consequence that has for their health, which seems now from some recent evidence to be even more detrimental than being long-term unemployed. These are issues that the country needs to be considering now at an early stage. Fuel poverty is another one. You know, the rising cost of fuel and the reduced availability of energy, that's also going to impact worst on the poorest in society. So we've got a challenge to be looking forward as well as to be addressing and responding to the evidence from the past.
Anyone else? No. Gil, were you anxious to come in there?
Yeah, I was just going to pose a point. It sounds to me that what's been said, it's almost too late when it comes to health services making the real impact. Have I got that right?
I don't think that is right. I think that the health services can play, and services more generally, I would broaden beyond the point that Graham was making. I think that all services need to have addressing inequalities as a fundamental part of what they're about. And unless they consciously think about that and plan and deal with evidence in a way that is concerned about differential impacts on different parts of societies, then services will not be playing their full part. But I think the point is that services are only part of the picture. We can't see the solution to addressing Scotland's health inequality as lying simply with the services in society. It also depends on redistributive policies, among other things.
Maybe I should articulate it a bit better. As a suggestion then that that the health service manages the inequalities rather than changing them.
Do you want to come in on that? Do you want me to come in on that?
I think it's very important to keep these two issues separate. What are we doing to prevent inequalities in the future, which is certainly across all areas of policy. And then the question is, what do we do when inequalities arise? And the reason why I particularly welcome the public audit report just before Christmas was that it did highlight this particular issue much more substantially than any previous government report. Usually comments on the NHS contribution are rather dismissive, and in fact I think you rather implied that by saying it was too late. And that may well be true for the kinds of initiatives that there have been, and they're well described, often short-term, lacking coverage, lacking continuity. We certainly don't need more projects of that type. But one of my major concerns is that the health service is not well set up to avoid widening inequality in the future by the mismatch of resource and need. And it's partly manpower, but it's also connectivity, the extent to which we've got too many cooks, too many specialist services, not enough integrated care around the experience and lives of individuals.
Is it still the case, I'll go back to some historical stuff when we've discussed this before, but does everyone accept that health has got a role to play in health inequalities? And it used to be a figure that was up to 50% of the health gap could be addressed by health measures. Certainly it was presented in evidence to a health committee that I was on some time ago when we discussed this. So health is... Does anyone disagree with that?
I think once as the population gets older, services become more and more important. You know, because there's been a huge almost explosion in the last 50 years in terms of what organised healthcare can do. Not just specific evidence-based interventions, but also well-coordinated continuity of care. And if that's not at its best where it's needed most, then it's axiomatic that the health service will widen inequality.
Anyone else? Dr. McCartney wished to come in.
Yes. I just wanted to build on the point Graham was making about the importance almost of separating out the service response from the causes and potentially the big solutions to health inequalities. And one way of thinking about it might be about mitigation of health inequalities versus the causes and the undoing of health inequalities. there is always this danger that when you enter into a discussion about health inequalities, you get this drift into talking, you start saying, oh, poverty is really important, or inequality in society is really important, but then very quickly you start talking about society or parenting or individualised interventions or health services, and we often call this the lifestyle drift. Hilary Graham, a professor in England, terms it in this way. But you could also see a sort of service drift where we start talking about the societal determinants of health and end up very quickly talking about the health services. And just to pick up the point that Duncan McNeill's made about the proportion of health inequalities that could be potentially accounted for by health services, or what proportion health services could potentially deal with, I think this is very problematic, actually, from a methodological point of view. We produced something in the Scottish Public Health Observatory called the Health Inequalities Tool, which modelled the impact of different causes of health inequalities and also the potential impact of different interventions. And it relies on a number of assumptions, not least that you don't get competing causes. As Graham Watt has already said, that in our most deprived communities, it's not just one single condition that afflicts people. They have multiple morbidity, they have lots and lots of conditions. And if you were to solve one condition, actually all these other conditions would be sitting just under the surface and would manifest themselves. And that's why thinking about the more fundamental causes, the more societal determinants of health are really important, because they determine all of these outcome measures, not just a single pathway. So if you imagine if we eradicated smoking in Scotland tomorrow, you could model that that would have a massive impact on life expectancy and a massive impact on health inequalities. But the truth is, other pathways would take their place. If you went back 150 years in Scotland, the biggest causes of health inequalities might be typhoid or TB. Roll forward 60 years, it would then be heart disease, cancer and stroke. You come to the present day, alcohol, drugs, suicide, violence would be big determinants of health inequalities. And they'll change again. In 20 years, it might be obesity-related diseases that causes these health inequalities. And by focusing on these single causes, we run the danger that other causes will just fill the gap unless we deal with the fundamental determinants of health inequalities in Scotland. But they're not inevitable. We've seen narrower inequalities in the past, and we see narrower inequalities internationally.
I think we realise we have a debate, because on the two sessions, I mean, on a direct question, I think it was from Gil Patterson last week to Harry Burns in terms of the poverty argument. And his response was, it would be a mistake to assume that poverty is the cause, he said last week. Why do some people succeed and others fail, he said. You know, so, you know, there's always a pressure on politicians to act and do something and whatever, but, you know, but we're getting different messages from the various people. Sally McIntyre.
I wanted to make a couple of points. One was Gil Patterson's sort of implication that is it too late for the health services to do anything? And I would say not, because the health services, universal health services, have a fantastic preventative and sort of inclusive effect. So if you think about antenatal care, health visiting, the fact that we have free obstetric care in this country, vaccination programmes for kids, school health. So these are all available to everybody. The uptake might be slightly different, but they're really important for preventing inequality. So I don't think it's just a case of the health services mopping up things in later life. I think the other point about, I highlighted Harry's reply to Gil Patterson in your earlier session, somewhat with horror, I have to say, because I think when you're talking about social inequalities, you're talking about socially structured inequalities whereby, on average, people from more poor backgrounds have poorer outcomes across a whole lot of domains of life, whether it's health or crime or whatever. He was picking up the point, and he's very keen on parenting, and we all know that, yes, it's, you know, good parents can help ameliorate and provide more resilience. But health inequalities isn't about parenting. It's about socially structured issues about poverty, unemployment, living in terrible places that cause these inequalities. So I think it's important that when we're talking about social inequalities, we're not talking about random variation. Why do some people do better than others in health? We're talking about these broad generalisations that life expectancy and healthy life expectancy is systematically different between social groups. And I think the problem with Harry's reply is he implied it's, you know, if you've got good parents, it's fine. If you've got bad parents, it's bad. I could go on about that, about the... Can I just make a couple of points?
Yes, certainly.
Yes. It's really about evidence, and I'm a researcher, not a policymaker or a practitioner. But in a report I wrote in 2007 for the Ministerial Task Force, I pointed out that you can think of policies to reduce inequalities at 3 levels. The sort of biggest level, which might be regulation or legislation. There's then local structural levels, and then there's individual approaches. So for education or a best start in life, you can do things to regulate standards in education. You might want to lower the age of minimum age of education. You can do local things like improve schools in certain areas or improve preschools, or you can focus on parenting and try and do individually focused things. I think what's been neglected, perhaps in Harry's view of what to do about educating in the sort of 0 to 3 years or the 3 up, is actually the structural things like better education, better preschool education. And I would be concerned if a focus on picking out potentially bad parents and giving them very intensive support takes away from the fundamental importance, if you want to reduce inequalities, of having probably progressive universalism in things like preschool education. That is, everybody has it, but perhaps you put more investment in poor areas and in groups who could benefit more. Sorry, I've then made 3 points of that.
Just to illustrate this point, I mean, most people who smoke don't get lung cancer. You could do a lot of research to try and work out who are the individuals who get lung cancer and target them so that smoking is okay except for a high-risk group. But we don't do that. We recognise that smoking is a social hazard, and we have policies to control it without knowing who will benefit and who won't. And I think we need to avoid going down to the level of individual explanations, because that's not going to guide policy in a helpful way.
As part of the problem, and you mentioned education, I mean, yes, David Liddell.
Just obviously to give the Poverty Alliance viewpoint, is that poverty and inequality for us is clearly at the heart of the issue, and that poverty is the killer. You know, whilst the relationship between deprivation and health is complex, the links between the two are clear, and I think, you know, we would take the strong view is that, as many of the contributors have said, is that we need to look at the fundamentals. And as Sally has said, I think employment, income and education are the things we should be heavily focusing on. I think it's right to separate the two issues of the role of health in reducing inequalities, but I think you know, we would argue that the most important bit that this committee should be looking at is those issues of power, you know, and resources and inequality, and how best to deal with those. And I think it's interesting for me at the previous meeting that issues around employment weren't actually mentioned at all as an important issue. So I think that's a really important issue to look at, both in terms of things like, say, community benefit clauses, all of these issues in terms of actually, I suppose, basically more state intervention, I think, in terms of reducing inequality, I guess, would be the fundamental point. I suppose the other bit linked to that, and we may come on to that later, is around issues around welfare reform, obviously, in terms of people being, you know, inappropriately pushed into employment, which I think is quite a different point from the bigger issue of actually looking at you know, employment as a key factor. And obviously at the moment we've got, I think the figures are 21% unemployment rate among young people now. And I think, you know, you only have to look back, as sort of Jerry's described in terms of different manifestations of the problems, is that, you know, you look back to the 1980s and the mass youth unemployment and the consequences of that. So I think those are the big issues that you know, I think that we should be exploring and looking at.
I mean, health, we have, you know, in health, maybe that's part of the problem. In health, the health department have accepted over various government that health inequalities has been their issue. It hasn't been a shared issue, but, you know, in the economy, remit or portfolio, inequalities will not be at the top. In education, inequalities are not at the top. Is it maybe just a failure then that while we've had the health inequalities as a priority in itself, that we should be having inequalities as a priority, and all these should feature in all these portfolios? Is that what you're suggesting? Sally, you...
There are inequalities in a range of outcomes, and I'm sure education should be concerned about inequalities of educational outcome. And other departments should be concerned about deprived communities. I think because health is so obvious, I mean, like the gap in life expectancy, you can say inequalities are killing people, and that is a very strong statement. I think some of the other inequalities don't have that sort of resonance of people saying, wow, we're killing people, we need to do something about it. But I think if you're going to influence inequalities in health, you have to target these other sectors as well. I don't know the politics of whether it is the case that these other sectors are not concerned with inequality.
Dr. McCartney.
I would just back up the point that Sally's made, and also the one that you made, that if we are to narrow health inequalities, we do need each of the departments in the Scottish Government, but arguably also in the UK Government, to be making whatever difference they can to narrow the societal inequalities that drive health inequalities. And health inequalities are special for the reasons Sally outlines. I stay a mile from Fergusley Park in Paisley, and when we did a community profile of that area, if you were a 15-year-old boy, you had a 50-50 chance of making it to the age of 65. And that's a profound injustice. It's unfair. It's kind of not the right thing in a civilised society. And because it's unjust and because it's a kind of mortal injustice, I think that's what should drive and spur action from the Scottish Government and the Scottish Parliament. And yes, it's a manifestation of these economic and other inequalities across various departments, but that outcome in itself, by virtue of accident of birth, you have that really high chance of dying prematurely, I think should bring us all, or give us all that kind of sense of horror and drive some sort of change.
Yes, good evening.
I mean, I'm particularly interested in a thing called the inverse care law, which is the availability of good health care being inversely in relation to need. But I think the same observation applies in education. I know GP colleagues in a very deprived part of Glasgow talking about their local secondary school in terms of the proportion of teachers who've been there for any length of time at all. So there's a manpower issue in relation to delivering education. We shared this with a journalist who wanted to speak to the head teacher, and of course the head teacher could not speak because of without jeopardising his or her position. One of the advantages of general practice is that it's independent. People can speak independently about policies and their consequences. So I think health is very much better described and analysed and commented on than other services.
Thank you. I'd like to encourage some thought about whether the issue here is one about policy or one about implementation, or the relationship between the two. Because I think in Scotland we could look at early years policy, getting it right for every child, which, as it says in the name, is about getting it right for every child, and therefore is concerned about differences by social structure, ethnicity and so on. We could look at the solidarity target in the poverty strategy and so on. And so I think if we looked across, I do some work in regeneration, and there's a clear commitment in addressing the quality of environments across Scotland to make our poorer environments improved and thereby improve the quality of life. So I think we could look across policy and we could say, yes, all of these different parts of government recognise they've got a role in supporting a more equal Scotland. And we might want to review those policies and see if they go far enough. But I think where some of the issues lie is then in saying, well, where are the resource flows from those policy aspirations? So are the policy aspirations realistic, or are they just hugely ambitious given the resource flows that come from them? And what does it actually mean when it then reaches the ground in different communities across Scotland? So we still have the situation, for example, where some school premises are available out of school hours for community to use for a range of activities, and other places where they're not. That seems, incomprehensible to me. I don't quite understand why that should happen. And clearly, if schools are a community resource that then can be used to give people opportunities in life, then they should be open everywhere. And we take another example, the Great Scottish Run or the Women's 10K. I know there's a Health and Sport Committee, you'll be interested in these. These are opportunities for people to be active. They're hailed as being big successes in Scotland. Thousands of people take part in them. But the gap between people in our better communities and our poorer communities taking part is about 6 to 1. So there would be scope, for example, in schools in poorer communities to actually foster people taking part in the Junior Scottish Run. So there are these policy aspirations, but in all sorts of ways they're not tracking through to realities on the ground. And I think that that's about resource allocation. I think it's about leadership. I think it's about what people see the job as on the ground. And it's about changing the dialogue about what sort of society we want and what success would look like.
You want to come back, Graham?
I think there's an issue of dose. I mean, quite often we get the diagnosis right, the treatment right, and the dose wrong. We just don't prescribe enough of what's good. We've got rid of homeopathic medicine, but we haven't got rid of homeopathic policy. Let me just give an example of the Millennium Development Goals set in 2000 worldwide. In the decades which preceded the year 2000, there had been a progressive slowing of reductions in infant mortality and general mortality. And since 2000, there's been a quadrupling of international aid for health, with a variety of programs for child health, maternal mortality, TB, HIV, malaria. There are lots of criticisms that can be made of those programs, but they have made a real difference. They made a real difference to child health, maternal mortality, and to the prevalence of these big infectious diseases. So I think being big and bold is part of the solution.
Yes.
I'd just like to pick up on some of the points that have been made by Carol and Graham in relation to some of the initiatives about being big and bold and some of the learning that we get from implementation and how important that is in terms of bringing that back into thinking about where we should focus our health inequalities policy. That we have offered to the Ministerial Task Force, which is trying to bring together action across the many portfolios across government, offered to review the current evidence and the learning that we've got from the initiatives that have been going on the ground to try and address health inequalities, to try and feed that back into policy. And I think we circulated a paper to you for the committee about that review, and we have two members of the review panel here with us today, Carol Tannehill and Sally McIntyre, who's chairing that review. And I think it's worthwhile actually spending some time actually focusing on what we've learnt from the past in terms of some of the, before we go too much further ahead in thinking about where we might focus our policies. The review that we're doing will be reporting in May, and I certainly recommend that to the committee. I don't know whether, Sally, you would like to say anything more about the review at the moment, but we're certainly, I'm sure the committee will be interested in that.
Sally's been volunteered, have you, Sally? Yeah.
Well, I think what we're hoping to do, as Erica says, is not just sort of learn from what's happened in Scotland, but look at the best available evidence throughout the world on what might be effective and cost-effective in terms of reducing inequalities in health. Just because I mentioned cost effectiveness, I think there has been a problem in Scotland in particular, and probably in the UK, of looking at what policies are effective in improving health, but that isn't necessarily the same as what policies are effective in reducing inequalities in health, and often cost effectiveness is left out. So we will be reviewing the evidence on the best ways and experiences elsewhere of reducing inequalities in health, but also learning from the more local picture. It's a shame about the timing, actually, shame about the timing of that review, both in terms of the Ministerial Task Force and this committee. It would have been better if we could have done that and presented that to you at your first meeting, and the same with the task force. So I just hope it will be of use to you and not too late.
On the question of research, of course, as an academic, I'm all in favour of evidence, but evidence itself is socially structured and patterned, and least likely to come from the kinds of areas that we're talking about. In my own area, the QOF, which is the evidence-based incentive system for general practice, only 12% of encounters with patients involve a QOF condition. So the other 88% involve other conditions, usually several. And we're only just waking up to the need to have an evidence base that represents the experience of the majority of patients, which is that they have more than one condition. If you look at the Scottish research system, it's substantially structured towards the investigation of single issues. And that is too fragmented for the experience of patients. And I think that one of the things that would be helpful to come out of your review is the extent to which the research system is asking the questions that this committee wants answers to.
There was a question, I think, answered last week, what I picked up in terms of the Health Inequalities Task Force. And I'll give you the opportunity to decide whether we take anything from that. But, you know, the last time we were here as a parliament, and there was a lot of intensive discussion about this, 2006, 2007, 2008, and there was the Health Inequalities Task Force met about 9 times in that period. Since then, it's met 4 times in total. Does that indicate that we've got a renewed interest now, or does it indicate an inconsistency in this area? Or yes,
I can answer that as I have the privilege of being a member of the Health Inequalities Task Force. It was established, first of all, and met monthly over a period of time and produced its first report. It then was agreed it should reconvene 2 years later to review progress, which it did. And then it has reconvened again 2 and a bit years after that, again to review progress and come out with a further set of recommendations. So I think that the periodicity you're describing simply reflects the fact that it was never established to be an ongoing task force. It always was established as a short-term task force to come out with some recommendations and then review progress periodically. And I think that given what we know about the entrenched nature of health inequalities, we have to be realistic about the timescales over which we will see progress, and also think carefully about what we should be looking for over a timescale such as 2 years.
So does everyone agree that it's not all that important in terms of meeting? It should just meet when... I'm going to get Bob in now. There's nobody want to pick up on the task force. Bob?
I've no set view on how often the task force should meet, I have to say. But in terms of what I've heard so far, again, the 2 roundtables we've had, the themes of economic inequality and welfare reform was mentioned, and where we can, where possible, mitigate the worst effects of that in all terms of social policy, including health policy. And again, need to put on the record that with not all the levers of power open to this Parliament, it will be mitigate rather than remedy. And I think that has to be said. But my question isn't what we can do, because we lament what we can't do as much as we like. It's what we can do. And I'm keen to know what's happening on the ground. And when we talk about health inequalities, what I'd written down was positive life experience. If you give people a better positive life experience, they're less likely to suffer from ill and detrimental health. So I'm interested to know how we do that on the ground in our most deprived communities. And I know Mr Watt was speaking to the Public Audit Committee about have we got the balance right about time spent with doctors in surgeries in the most deprived areas, and are you just firefighting significantly serious medical conditions, whereas in other parts of the country, other regions, you can look at doing some positive health messages. So on the ground, I'm keen to know what works well in our deprived areas in terms of the NHS, be it general practice or elsewhere, and not just telling people how to be healthy, but asking them what would they like to do to be more healthy. So the idea of social prescribing, the idea of not doctor knows best, but other examples of activities coordinators around health centres who can suggest other things to do in their life. examples of signposting towards the local skills agency where you can pick up training and apprenticeship opportunities, other positive relationships with housing associations, because we move towards integration. I'm keen to see a model on the ground which isn't 10 minutes with doctor that says we've spent 9.5 minutes making sure that we know what the latest bad thing that's happening to you in terms of your health, and 30 seconds left to ask you how you are in yourself more generally. So what's happening well on the ground to find that time for doctors or other professionals to have that kind of positive engagement with people who are most at risk of health inequalities?
Can I come back? I think that the first thing I would say is that the health service is most equitable in dealing with emergencies in hospitals. In Glasgow, we're building the biggest acute hospital in Europe to deal with the consequences of not preventing things. Where the health service is inequitable is partly in terms of access to specialist services, which is a whole separate area, but also what Bob's talking about in terms of the quality and quantity of care that's provided at ground level. You ask for a model. Well, I would say it would have several components. One is that it's unconditional. It's not dependent on what people can provide. It's dependent on the problems that people present with, or particularly the combinations. The intervention is not a single intervention or a one-off intervention. It's a serial encounter. The key silver bullet is the relationship between patients and an individual or a small team whom they come to know and trust. And the fact that it's a serial encounter means that there's opportunities for false starts and starting again. General practice is by no means the panacea, clearly, but it does have continuity, coverage, and contact and relationships for most people. And that's a huge structural resource around which to organise things. People do need to have more time, because we know that in the absence of time relative to need, patients are less likely to report being empowered by seeing a professional, especially if they have a mental health problem, which is the commonest comorbidity in deprived areas. At the same time, the practitioners describe being very stressed, because after each consultation there's another long one to come. The pressure needs to be taken off that for both patients and practitioners in order to reduce the adverse, chaotic, episodic nature. Serial contact with a relationship provides the opportunity to link into all the things that you describe. The huge resources within communities, the third sector, area-based health services. We don't lack resource. What we lack is the social capital that allows us to make best use of the resource. And essentially that's a whole plethora of relationships. And in some ways, the relationships between practitioners and patients are the healthiest. And the most dysfunctional relationships are those between professionals and between services and between management and practitioners delivering. So my model would be unconditional. There's sufficient time to get to the bottom of problems, which means that there needs to be flexibility available when you need it. There needs to be a focus on the serial encounter, not just the beginning of things. There needs to be shared learning so that you don't have 1,000 ships passing in the night. You need to have much more support for this from central organisations. The main NHS support organisations are notable by their absence and low profile in deprived areas. I think that's another area this committee could quite usefully ask some important questions on. And the other thing is that you need to invest in leadership at ground level for the building of social capital. And you need to invest in better relationships between leadership at ground level and at area level, because I think that's often the most dysfunctional in terms of the lack of understanding, the lack of mutuality, and the lack of respect. The thing that links all that together is investing in human relationships, because that's the one resource that we're not short of, but it's the one that we tend not to try and invest in and manage.
Anyone else to Bob's question? Mr. Liddell.
Just to pick up on the issue of local resources, I think there are very many valuable community initiatives to tackle health issues and bottom-up initiatives, but often they're funded on a shoestring and obviously funded short-term and come and go. For example, there's lots of good examples. Say I think it's the excuse me, the Castle Milk Stress Centre is a good example. A number of those initiatives, but I think it would be useful for the committee to actually explore those in more detail and look at how the problems of actually evaluating those initiatives, but also getting appropriate resourcing to fund those over the long term is really important to add to the actually more direct health services issues. If I could pick up actually on the GP issue as well, in terms of there are models I think in other countries where they've actually looked at adding to the GP resources in the more deprived communities. For example, I think in Australia there's a good example of that where they've actually had state funding for training of particular general practitioners with a condition that they actually work in the most deprived communities for 5 or 10 years after their qualification. So there may be models that the committee could actually look at which might be cheaper than some of the existing approaches to delivering health and combating inequalities in the more deprived communities.
Yep. On a supplementary on that issue, Richard? No, I'll let you in there.
Well, it's following on from that, but it's...
Did you want to come in there? Yeah, sorry, Richard.
I'm happy to come in. I agree with both of these points. I think there's a real challenge here, though, about incorporating this attention to social relationships, a relational way of working into mainstream approaches. I don't think it can be addressed through a number of projects. There are lots of good examples of the sorts of approach you're describing, but they do tend to be short-term funded, and their reach is not enough to impact at a population level. So unless we manage to move to having concern with some of the issues that Graham has described as part of the day-to-day job of people working in mainstream services, then we're not going to improve the situation from where we are.
See just on that, Convener, I mentioned GPs, but I was also interested to hear what other kind of health professionals you think have got a role. If someone goes to, so to give you an example, if every year I go to a launch of something called the Maryhill Activities Directorate, it's hundreds of different clubs in the local area that aren't always very well attended, but they do a fantastic job and there's huge opportunities out there. Now, I can appreciate a GP in a 10-minute slot may not have time to chat about opportunities in the local area, but there's community pharmacists, there's dentists, there's physiotherapists, there's a variety of other people. Should other professionals have a frontline role in tackling health inequalities? Are they doing that currently? Or is there scope for them to do more of that? Does everyone have a responsibility and it's not just that 10-minute slot with a GP?
If you look at PTI data from the 60 Scottish general practices that inform a lot of primary care policy, 20% of people don't go and see their GP in a year and probably don't need to. About 70% consult 1, 2, 3 of like most people around this table, professional, generally healthy people who need the doctor occasionally. And then there's about a sixth of people who account for half of all the work of the health service. So I think you need a plurality of services. Not everybody needs the relationship with a generalist. Some certainly do. Some people don't need help from health services at all to live long lives. And other people may well get what they require from pharmacists or from other services. The problem with plurality, and this is always one of the problems with the market, is that you don't know what's going on, and particularly you don't know who's getting left out. And the advantage of the NHS in Scotland is that the list system does give us a denominator which allows us to measure what's not happening. And that's really key to addressing inequalities, because we shouldn't just be measuring activity, we should be measuring what we're not doing. And when services are very diffuse and pluralistic, it's difficult to have a handle on who's not getting what they might be getting. There's a problem for the health service in that denominator is actually based on GP lists and not on area-based denominators. And so much of our research is based on geography. Whereas the community that the health service deals with is a community of interest through its point of contact with primary care. That's not always geographical. And there's a mismatch there that's quite challenging to address. Just one other point on the issue of what we're actually trying to achieve. I think the unit of currency is the patient's story, what their experience is. And the job of services is to improve the knowledge and experience and confidence of patients, people, living with their conditions and making use of the resources that are available. So that's the story we're trying to create. And the sum of what we produce is the compendium of stories. So we don't need to necessarily be evaluating a stroke program or a hypertension program or a keep well program. It's the compendium of stories that exist at a local level. And the conjecture is that if you're investing in people's knowledge, experience and confidence of living with their conditions and accessing the resources that are available, they will live longer and more successfully in the community without chaotic use of, for example, emergency services. I think that's the road we need to go down.
Anyone else? Dr. McCartney.
It's just a reflection, I suppose, on the last 10 or 15 minutes. When Bob Doris originally asked this question, it was about how can we promote positive life experiences in deprived communities. And I was kind of expecting people to say, well, that would be about gaining employment and having enough income to live in and having an equal sort of community, having good housing, what have you. But we've just experienced the lifestyle drift where very quickly we've started talking about individual level experiences. We've talked about trying to direct people to sports clubs. And although that's a legitimate conversation to have, and we need to do that better, there's no doubt about that. Again, is this danger of having an overwhelming focus on individuals rather than having that population level view, which we know is what drives health inequalities. So it's just something to remind the committee of, that this lifestyle drift happens all the time in every conversation we have about health inequalities, every time we set out to do a policy, every time we make recommendations, we end up drifting down to discuss individual level interventions and individual level factors.
On this theme, Richard?
Yes, I mean, I think I can fully understand what Dr. McGarvey is saying, but the problem is that you go back to the big policy issues and say you want to eliminate child poverty, you want to have full employment, which were the two big things that the Labour government came in 1997, and we moved to reducing child poverty by a third. We increased employment to the fullest it's been since the 60s. So we should be seeing an effect from that. We should be seeing a benefit from that. But that's primary prevention, and that's what you keep saying. And of course, the governments have got to look at that, and if they don't look at that, then they'll never solve the problem. But it doesn't alter the fact that we've got a whole generation who've suffered the initial years, suffered the poor education, suffered the child poverty, and we have to deal with them as well. We can't write them off, as Gil was saying. Is it too late? So the question is, are any of the things that we've been doing, like, for example, Arbuthnot and now NRAC, do they actually come through to the ground in terms of the allocation of resources to deal with deprivation? Because we're supposed to, at a national level, have an allocation system that takes into account deprivation. Do we do that? Well, the audit reports seem to indicate that we weren't. So, how do we actually make some practical steps? Because no one has succeeded in that. If you look at the Public Accounts Committee report from the UK, it's one of the most damning reports of a failure of policy intent that I've ever read. That was at a UK level, but they were really blistering in their attack on the delivery of the policy intent. It was really bad. So we've got basically equally well, keep well, seems to me to be largely divorced from general practice, which is where it really, in my view, should be at. And I don't understand and don't see, and I'm not hearing from the witnesses, what practical steps can we take rather than playing about with further tiny policy things, tiny initiatives, testing things out. Are there not some really significant things that we could do that focus on the multi-morbidity, both social and health, that are in some of these deprived communities by focusing on the practices? I mean, the Deep End group are the one that have emerged. By focusing on that Deep End group, putting policies in there which give them the resource allocation that they have not got, either as GP numbers or as allied health professionals, nurses, health visitors, etc. If we actually did that and said we're going to actually put substantially greater funds and we're going to offer them a change in contract which allows them to not have QOF addressing the 12%, but actually addressing all these other issues. Would a radical change in policy of that sort actually work? And telling the health boards that they must apply the NRAC deprivation funds to these communities, which they don't appear to have done. Or have they? Sorry, there is a question in there somewhere. But it's more a frustration that I feel after 12 years being associated with the Parliament side of things.
I think that there are two issues there. One is resource allocation, and two, what you do with it. Arbuthnot and NRAC were very well intentioned. They had the best data, the best intentions, the best methods, the best statisticians, but nevertheless failed to address a particular problem. You know, when needs are invariably converted into use of the health service, particularly through emergencies, they can be counted, and that was the strength of both approaches. They could assess need for hospital care and produce a formula that reallocated resources on that basis. But what they couldn't do was redistribute resources on the basis of unmet need. And here we come to the point about numbers. And there's disinformation in the evidence to you last week about GP numbers, because the audit report, whilst quoting recent ISD data, I think produced rather misleading information on GP manpower. The most recent data based on whole-time equivalents is 10 years old, because the government stopped collecting the data with the new GP contract, and that shows a flatness of the distribution of manpower. It's not the case that there's 25 to 30% more GPs in deprived areas, as I think the committee was told last week. That's based on a misinterpretation of inaccurate data in the audit committee report, largely due to the undercounting of GPs in the most affluent area. So I think that is a real constraint, the lack of manpower. But in answer to Richard Simpson, the DPEN group does have a set of proposals which it's almost at the point of completing and sharing. It's not by any stretch of the imagination a simple business of plonking GPs in deprived areas, as was described last week. There does need to be additional capacity, and it's either through vacant slots in surgeries so that there's always the ability to spend longer with a patient because you don't know who will turn up, or it could be based on the Care Plus study, which is investing extra time in particularly needy patients. Probably both approaches are needed, and there's a variety of ways in which that additional capacity could be weaved in to the existing strengths of local teams, because we're not talking about new build or new teams. And allied to that, there needs to be investment in attached workers. I think Nanette Milne was talking last week about the model of the attached health visitor and the social work, where they knew each other and worked coherently. That needs to be regained, the coherence of local teams. The attached workers is, I think, to some extent, anathema to area-based services for addiction and mental health services, which see them as inefficient. But when you're dealing with high-volume caseloads, there's a case for attached workers. There need to be link workers, and there's lots of projects on the go about that, linking the cumulative knowledge of primary care teams of their patients with the resources within communities for a whole lot of things. It's not just an informational thing that can be solved by a website like Alice, important though that is. There are relationships that have to be built in order for those resources to be used. And then there's the whole infrastructure issue of the training, the fellowships, the information, the research that makes it a coherent, shared learning experience. And you know, when we do produce these proposals in just 2 or 3 weeks' time, we're not prescribing with the I's dotted and the T's crossed. We're suggesting a direction of travel in which lots of people need to be involved. And the big challenge is not actually the resource issue, because I think that could easily be worked out almost on the back of an envelope. The real difficulty is getting services to work coherently together, because underpinning this is inevitably a transfer of power and responsibility and accountability from areas to ground level. So I don't for a minute underestimate the challenge of doing that. But if, knowing what we know about the epidemiology of multimorbidity and demography, the question is, how is the health service going to use the resources available to it, principally manpower, to avoid inequity in what it achieves? And I think that requires something of a new direction, a new partnership, if you like. And I mean, asking for, people could say, well, is this going to work? Well, probably the best evidence is that uncoordinated, partial, incomplete care, left hand not knowing what the right hand is doing by people who don't know what happened previously and don't have a commitment to what's happening next, is a recipe for premature use of emergency services. That just seems to me to stand to reason. It's not a question of whether we try and do things differently. It's a question of how we do it.
I suppose it takes us to some of the I don't know whether anybody wants to comment on that, but some of the issues that were supposedly put in place to address that. When again we discussed it with the Chief Medical Officer, in April 2006, when he agreed at that time that we had to enhance the primary care service by batching increased performance with increased number of GPs, the health partnerships, community health partnerships, and Bob and I endured 4 years of the health committee, trying to get single outcome agreements that we believe should have had that poverty within their indexes, and we're not quite sure what happened to those individual single outcome agreements over the period of time, but many things have been tried to try and bring about that coordination. And a couple of weeks ago we heard from Derek Feely that we were now talking to COSLA about some of these issues. So we talk about this quite a lot.
Well, we put in evidence on the consultation for integrated care, and we ignored the first 15 questions because they were all about managers meeting at area or locality level, which is an important issue which hasn't been cracked yet and may or may not be cracked in the future. But much more important is what are the wheels that need to be oiled for integrated care to work around the needs of patients? And that's much more to do with professional relationships and between services. And it's important to get people sitting around the table in localities to agree to work together. It doesn't happen in terms of resource distribution unless that is the case. But at the end of the day, the patient experience depends on how a small number of people work well together in their care. And I think that needs to be at the heart of integrated care, not the managerial relationships.
Anyone else? Yes?
I'd like to raise a point of some of the difficulties that you address in terms of what happens to all these resources that we put in, and yet we don't seem to be achieving any effect in terms of the high-level outcomes, and the difficulties of actually tracking through the system how those resources get used and deployed in services, the partnership working. And it's a very convoluted system through which that goes. And I think we need to get better at having much shorter term outcomes in terms of assessing our progress, in terms of reaching the higher level outcomes, which are about reducing health inequalities. And I think you heard from Harry Burns and Derek Feely, who are advocating this in relation to the early years area, around looking at shorter term outcome measures on the pathway to reducing health inequalities, like, for example, delayed development, I think they were talking about. So that it becomes easier to actually see whether the investments you're making are actually translating itself in terms of the sorts of outcomes that are relevant to particular services. And I think if we get a bit more clever at identifying what those shorter term outcomes are, we'll probably be better at tracking progress along the path.
Bob, did you want to come back to that?
But not on that specific points. If that you want to develop that further, it was more on following the money through. Convener, we're hearing about NRAC, and Richard Simpson was talking about that. I was going to ask a question about that, so maybe move on.
Well, I could maybe just build a wee bit on the point that Erica's made around some of the difficulties we've got in learning from some of the initiatives, and Keepwell's as good an example as any. Both Erica and I are involved in the latest round of evaluation of that intervention. And the way in which it's been implemented has meant that it's been incredibly difficult to get any evidence of the effectiveness of the programme. And I know that you heard some evidence previously about based really on anecdote that it was making a difference, but we really don't know. And there are always dangers with introducing services, particularly services that have got a screening orientation. Members might be aware of the controversy at the moment around breast cancer screening, and it's not that breast cancer screening was set out to be a bad intervention, it's just that when you find cases in the community and start treating them, there's a danger of over-treatment. And there's those dangers around things like Keepwell, where you find cases that hadn't and wouldn't have presented necessarily to services of their own ilk, but you then start treating them and you get treatment-related conditions as a result of that. And so it's really important that we evaluate these things properly, but we're continuing to put in place interventions without counterfactual groups, without control groups or comparison groups, to allow us to see what the intervention effect is, without allowing us to see if there's any adverse consequences, without the ability to understand the short-term, medium and long-term outcomes, and then transfer that learning. So we're on this cycle of consistently bringing in new health improvement interventions, often with an aim to reduce health inequalities, without really knowing very much about what worked from the last cycle. And we can go back, and people around the table who can probably go back further than I can, but to previous interventions like Have a Heart, Paisley and back. What did we learn from those? What learning did we then apply subsequently? Did we know that they worked? What were the adverse consequences? Did they narrow health inequalities? And we probably don't know the answer to very many of those questions, and yet we continue to devise and promote more health improvement interventions. We've heard suggestions around the table again today of more things we could do, but have we learnt from what we've done already, and will we make the same mistakes again? And once again, they're often individually orientated rather than dealing with things at a population level.
More health improvement interventions. They usually follow a screening mode. They generally lack coverage. They talk about people being hard to reach. That's really a function of the screening process. And they lack continuity when the funding runs out. They're all front-ended. They're the start of a process. And the question is, what happens next? Keepwell has processed huge numbers of people very usefully in terms of assessing their risks. But what happens after that? I think that it's important to remember that there's only one general public, and that should be our focus. But there's the public as seen by Keepwell, as seen by mental health services, as seen by addiction services, as seen by this group and by that group. And if you, as I've done, sat in a meeting of professional groups concerned with child health care, you sometimes think that the number of children around must be very much bigger than it actually is, because there are so many services looking at different aspects of children. There's only one public, and that should be the unit of our evaluation, whatever services they're getting. And I think this is, to go back to Jerry's previous point, there are public health policies that don't require contact with the public, and they're probably the most important ones in relation to the issues that we are talking about. And that's the job of public health, I think, to address those kind of policies. And then there are policies that do require contact with the public. Well, we've probably too many of them. Primary care has got contact with the public. It's got coverage and it's got continuity. What it lacks is the resource to harness those resources. So we don't need to reinvent a way of contacting the public. We need to make better use of the contact with the public that uniquely in Britain we have because of the NHS.
Anyone else on that? Because we have this, you know, I think it was discussed last week with Harry Burns, and certainly in previous sessions we've had this debate about outcomes and monitoring and all of that. And the message that seemed to be coming across was that we really need to get on with it. That we're doing a lot of small projects and we need to be doing bigger, and we need to, I think, just stick to them. You know, just push them on. What do you think that we mean by all of that? Graham, I'll let you back in a minute, but Professor Tannehill is going to come back now.
Okay. I'm a bit more optimistic than Dr. McCartney is about this. I think we are learning, but I've got no doubt this is a long-term challenge that we're facing, and I agree with Erica. We need to find ways of learning more effectively as we go. I wanted to pick up on one methodological thing and then recap on some of the things I think we've learned. The methodological thing is about cost effectiveness, which was an issue that was highlighted in the Audit Scotland report. And cost effectiveness, of course, simply takes into account the cost of doing something and the effectiveness of that intervention in achieving the desired outcome. But one of the issues is that cost effectiveness varies by the population group that you're delivering the intervention to. So the cost effectiveness of smoking cessation services is much lower in our more affluent communities than it is in our poorer communities. And so people talk about smoking cessation as being a cost-effective initiative, but at one level that doesn't make any sense. It depends how you're delivering it and who you're delivering it to. And as a society, we need to think about the value we place on people going through services like this. So is it worth to Scotland just as much to improve the life expectancy of someone in a poor area by 1 year as it is to improve the life expectancy of someone in a more affluent area by 1 year? I would hope it is. I would hope we would value all of those lives the same. It's going to cost us a lot more to do it in the poorer area. And therefore, if we're driven purely by cost effectiveness without some sort of value metric being placed alongside that, we are not going to shift our system towards interventions in our poor areas or to address greater need. I hope I've explained that well enough, but it's a caution around being driven purely by cost effectiveness, and there is a risk at a time of austerity that cost effectiveness becomes the primary focus and some of our other values are put secondary to that. In terms of learning, we do need to learn from interventions, but we also need to come back to where we started today. What we can learn globally is that if we can work towards establishing a more equal society, then there will be benefits to all in that society, not only to the poorest of, and our health outcomes will be greater and our health inequalities will be greater. That issue of redistribution should cut across all aspects of society and all the services that are provided in society. And I think it was Sally talked about this term proportionate universalism. In Scotland, we haven't had, I think, enough clarity around what that means, how that can be delivered across all aspects of public service, and what level of proportionate is necessary to reduce health inequalities in Scotland. And I think that that would be an area that would definitely be worth further consideration by committee. And I think it picks up on Dr. Simpson's question about NRAC and how that then tracks down. Does NRAC give us an adequate amount of proportionate universalism at a national level? And how then is that being translated across all aspects of society? And I would urge you not only to look at health services, but to look at the range of public services, because they will all have a role in reducing health inequalities.
Thanks for that. Okay.
I think Carol's point about proportionate universalism is one of the most important points of the morning as a yardstick against which policies should be developed and evaluated. And certainly from a deep end point of view, we're trying to make proposals that should be applied pro rata, not just to a target group. On cost effectiveness, the early cancer detection program for bowel cancer was introduced on the basis of evidence of cost effectiveness, but that was on the basis of a response rate of about 60%, largely excluding deprived areas. So the cost effectiveness data were very context specific. And I think it does need to be set in context. Each local health system is a microeconomy where there are lots of currencies being juggled. The main one is time. There are lots of incentives and disincentives being managed. And I think simply to set up a scheme like that and put it into a context without considering the wider microeconomy, I think is a problem. And I think that's why the Cancer Early Detection Programme may well be one of these initiatives that has a perverse effect in terms of inequality. I'm going to try and ration my contributions, Chairman, because I feel I'm speaking too much, but my parting shot would be that the Audit Committee, I think, has highlighted the inverse care law as an important social determinant of health. And my view is that it's perhaps the first to do that. And many of the reports on the social determinants of health have not really grasped the extent to which public health services, by inequitable distribution, can be a social determinant of health and therefore of health inequalities. So we hope that's the beginning of a new look at that particular issue.
I don't want to cry your self-discipline, but I need to ask you, because the issue about the inverse care law and the gap that has widened over that piece, you know, when that was raised last week, I think Harry Byrne says that the gap has widened despite the things that we do, not necessarily because of them.
I'm not aware of any serious attempt to address the inverse care law in Scotland insofar as it involves general practice.
But you were suggesting that some of the practices that we have, bowel cancer, we're widening in that gap. How do we if we hadn't introduced that, I think the argument was made last week, if we hadn't introduced that, how do we know? How do we?
Well, we had a meeting with the team that runs the national programme who wanted to talk to deep end practices, and they provided the locum fees that allowed us to have a roundtable discussion. And one of the main issues was that the delivery of that programme in deprived areas would be much better if there was a sitting down between the national plan and the local practices to work out how to work together. You know, for example, if there was a focus on the campaign for 1 month a year where the practice and the national campaign were working together to use all opportunities to involve patients, then there would be a greater likelihood of engagement than there is if you're simply writing to people from Dundee with an envelope and asking people to collect stools. That's a very unlikely thing to happen in the deprived practice. So in that particular issue, I think the thing that was missing was the principle of co-design, where the delivery at a local level is discussed with the people who will deliver it at a local level in terms of their context and constraints.
Okay. Drew Smith, and then I've got another couple of committee members that I want to bring up. Oh, sorry, Dr McCartney, carry on.
Well, just very briefly to follow on from Graham's point, in the paper that I think was circulated in advance of this meeting that I'd written, which drew upon Sally McIntyre's paper to the Health Inequalities Task Force, I think in 2007 or 2008, there's a kind of couple of tables which outline those kinds of interventions which are more and less likely to exacerbate or narrow health inequalities. And things that rely on individual agency, that is for people to opt in, such as bowel cancer screening programmes, they are the kinds of things that are much more likely to exacerbate health inequalities. Whereas things that you can't get out of, so housing intervention, for example, or smoke-free legislation or minimum unit pricing for alcohol, these are the things that are most likely to narrow health inequalities. But I don't know if Sally would like to go into more detail on that.
Well, just picking up a point that Carol made about values, if bowel cancer screening has a differential uptake by social class, say 60% among higher social groups and 30% among lower social groups, if both are benefiting, you might be increasing inequalities, you might be increasing a gap, but if both are benefiting, should you then abolish that policy? So I think there is an issue about saying widening inequalities is always bad, because if the poorer groups are still benefiting, then you might then look at that programme and think, well, how can we get them to benefit more? And this is the proportionate universalism and what resources they need. But I think there is an issue about an absolute thing about this has widened inequalities, so it's a bad thing. It may have widened inequalities, but everybody's benefited. They've just benefited differentially. So I think that's an important point. I also wanted to go back to when you said to Harry Burns last time that some programmes had widened inequalities. He said, no, they've not. The gap has widened in spite of it. And again, in 2007 in my paper, I pointed out that inequalities do seem to have widened probably since the Second World War, but that is not a reason to abolish the NHS, free education and universal services. And that has been an argument some people have made. So you're saying to us that with the NHS, with free antenatal care, with immunisation, with education, etc., all the welfare reforms post-Second World War, inequalities widened, so we should abolish them all. And I don't think that's the case. And I'm wondering whether that's what Harry was responding to, that actually if we hadn't had those things, inequalities might have widened even more.
Yes.
Just to add to that, I suppose in terms of obviously the impact of welfare reform on health inequalities as well, I think that's an important area for the committee to look at in terms of the economic situation and the impact of welfare reform, and in particular some research that the Poverty Alliance has undertaken looking at the use and availability of food banks. I think is one important aspect of that, where certainly it certainly is not fully understood and requires further investigation. However, evidence from the research in Fife has clearly shown that women in the study were regularly skipping meals in order for their children to not go without. And obviously the physical health impacts of such behaviour over the long term are a real cause for concern. So I think just obviously that, you know, the points about the General Health Service in terms of everybody benefiting, but obviously the welfare reform in particular in the economic situation is the exact opposite of that.
Drew Smith.
Thank you, Convener. The question I wanted to ask was around the issue of accountability and where accountability for all of this should lie, because I think it was Professor Watt quite early on said that there's a professional community involved in inequalities at a policy level, but then there isn't necessarily the manpower across the National Health Service and all the other associated organisations that need to be involved in this, who are directly involved in driving inequalities. And inequalities policy is something that happens up here, and we all say that we know everyone else needs to be involved, but where is the evidence that they are, or if the evidence that they are isn't there, then it raises the question of where accountability lies at every level, both at the top level around government, around how do you actually create a meaningful target that says, you know, we want to make progress and we're going to measure it against this, and then how do you put that down through the system? Because otherwise, you know, we just end up in these periodic committee inquiries every 4 or 5 years where people say, well, it's, you know, hugely complicated and everyone needs to be involved and everyone's responsible, therefore no one's responsible.
Both.
Just a brief comment on that. The Scottish Government do publish annually a long-term monitoring framework on health inequalities, which has a basket of outcome measures on health inequalities. And although it's imperfect, as all measures are, it's the best available data we have. And it includes things like indices of inequality for all-cause mortality, for admissions to hospital for heart disease, down to the differential across society and low birth weight babies. So that's a good basket of measures. At present, I don't think they have a specific target for that, and there would be a question about whether you would have to have a target for each of those outcome measures, or you would pick maybe all-cause mortality or the like. But certainly there are means there to monitor progress.
I think it's an extremely good question, because it's one of the big challenges, I think, in relation to community planning partnerships, where health inequalities has been identified as one of their main priorities over the coming years. And community planning partnerships are accountable for the outcomes. So what outcome exactly is it going to be in relation to health inequalities, and how will they be held to account? And I think this is one of the things that the National Community Planning Review has been trying to look at. But mutual accountability, joint accountability across those partners is actually very difficult to implement. I mean, I'm not sure what joint accountability will look like. Do they have shared systems for monitoring those outcomes? I mean, the problem of sharing information across a partnership is one of the key intractable problems that we've had in terms of partnership working. So I think you've hit the nail on the head in terms of how do we hold people to account, but I don't think we've found a solution for how to do that. And I think it is one of the things that we will need to address in terms of if we're going to make any progress through community planning partnerships in addressing health inequalities.
Anyone else?
The thing that brings it down to ground is the experience of patients. You know, whatever people say they're trying to do, it's the experience of patients that counts. A lot of the documentation that's produced around inequalities is simply advertising good intentions and activity, and you don't know what it achieves. And I'm not sure that I'm suggesting something that currently exists. It may need to be imagined and invented. But I can't think of anything else that would bring the thing down to ground than something that was based on patient experience. And increasingly, I think patients will be determining their own goals. It won't be whether, a colleague, Jan de Messner from Ghent in Belgium, was talking to us about the typically morbid, multimorbid elderly patient with many problems failing to get what she needed from fragmented services. And the thing that turned the corner was asking the patient what she wanted. And increasingly the goals were functional and social. They were to do with going shopping and playing cards, that sort of thing. And the diabetes was actually secondary. So, I mean, 100 years ago, people said, listen to the patient who's telling you the diagnosis. Nowadays, we need to listen to the patient who's telling you what our treatment goals are, and that's the currency with which we should be evaluating services.
Does Sally do you want to respond in any respect? Just in terms of your paper, where the objectives of your paper were to measure and understand the problem, do you feel there is a measurement and crucially an understanding problem since you've wrote that paper?
In terms of this issue about accountability, or more generally?
Well, yeah, and the responses that we've heard.
No, I don't think I'd like to comment at that.
Right, okay. Drew.
I suppose the challenge in what Professor Watt is saying, though, that in order, the people that you're talking about, asking about their experience and taking understanding experience, then trying to shape policy on the back of their experience, are exactly the same people that professionals will tell us are hard to reach. And so this goes back to the big conundrum in this. And I suppose Dr. McCartney was talking about lifestyle drift and the danger of making policy around, I suppose, trying to change people's behaviour, whereas you're kind of saying the opposite. Not in a disagreement, but in two different ways of using that idea of where we rather than trying to make policy around changing people's behaviour, we should make policy around learning from people's experience, which is kind of talking about individuals but talking about them in two different ways. Is there any more I can tease out of that?
There's a couple of different things that might be getting confused here. In terms of learning, there's broadly two types of research. There's qualitative and there's quantitative. And if you're asking why questions or how questions, then you want to gather qualitative evidence to help you understand that process. If you're asking a what question, then you want some numbers, some quantitative evidence to tell you how much, or what the difference is across a population group. Now, that's about learning. There's a difference about outcomes. So the outcomes that I described that the Scottish Government are currently using are sort of hard quantitative outcomes. So it's counting how many people end up in hospital or how many people die from particular conditions. You could easily add to that other measures, and indeed there's one measure on mental well-being and inequalities in mental well-being across society that's used as part of the current basket. But the kind of things that Graham Watts also mentioned, say social capital or functioning or such measures, part of that's included in healthy life expectancy, so how functional you are in your own context, and that's encapsulated in one of the measures the Scottish Government are using. But you could add others in, depending on what's important, and I suppose what Graham's perhaps proposing is that we could do more research to find out what's most important for patients and then add in those outcomes, and that's not unreasonable. The advantage, of course, of these harder outcomes is that you don't have survey biases. So if you die, you're counted in the numbers. We don't have people in more deprived areas that disappear from the numbers. Whereas with some of the survey estimates we've got, for instance, in the Scottish Health Survey, the response rate is hovering just under 60% at the moment, and we know that no matter how much you weight up the responses in deprived areas, respondents are different from non-respondents. And so any kind of survey measure always has that kind of danger. And I know that there's lots of work going on to try and minimise those biases, but at least with the harder outcomes, you don't have that danger.
You finish it? Is that a supplementary, Rich? Because
it's to try and tease out what Dr. McGarvey was saying. I mean, the one area in which there has been a narrowing of inequality has been in the cardiovascular field, as I understand it. Now, it's not massive, but it hasn't broadened. And if smoking, for example, was the big issue in relation to that, you'd have expected it to broaden because the socially deprived areas are still smoking. People who are socially deprived, poor socioeconomic groups, still smoking at over 40%, whereas in socioeconomic groups 1, it's 10%. So, we haven't succeeded in narrowing that smoking element, and yet cardiovascular has reduced. Now, as I understand it, part of it is because of improved technology, but part of it is due to lifestyle stuff. Can we tease out why that actually, even if the narrowing hasn't been great, why that hasn't actually gone the way of other areas of broadening the inequalities as they've all improved?
Yep, and this relates back to something I talked about earlier on about if you look back over history and different causes of mortality. So you're right, cardiovascular disease inequalities have declined on most of the measures that you described. But what's happened in their place, we've had inequalities rise in things like alcohol-related mortality and drugs-related mortality and violence and suicide. And so where the gaps have been left, if you like, other causes have taken their place. So all-cause inequalities in mortality have pretty much stayed static, whilst the inequalities in cardiovascular disease have come down. And this is the danger, again, of focusing on individual causes. So smoking, services, better housing, better income, all of these things will have had an impact on cardiovascular disease mortality and their inequalities. But without focus on the fundamental causes, other cause-specific mortalities will intervene and we'll end up with the same gap in all-cause mortality that we had before.
But that didn't really answer the question as to, okay, accepting your point that you need to tackle the thing as a global issue, we need to do with education, child poverty, housing, all the big issues that this committee is not really focused on, although it's obviously part of our report, and you keep stressing that. What did we do right in cardiovascular? Because it wasn't just that it's come down by 40% generally, but in that process, it's the one area where it has actually narrowed the gap. So were we doing anything, or we just say, well, that's just chance, just happened to be, we don't know what happened? Has anyone actually worked out why there has been a narrowing in that area? Because if there is a reason, then we might be able to start applying it to some of the other disease-specific areas, which we have to tackle alongside the major issues, in my view.
I don't have a good answer to that, I'm afraid. The best I can think of was some work that was done at the University of Liverpool by Simon Capewell and colleagues, who looked at the range of factors that influence the decline in cardiovascular disease overall rather than the inequalities in cardiovascular disease. And they attributed quite a large proportion of that to improvements in treatment. If that's true, then you could imagine that perhaps we've managed to make access to treatment more equitable, but I don't know if that's true in the Scottish context.
The evidence is the opposite, and as I understand it, the access to treatment, because people the people from poorer communities access that treatment much later. Once they get into the process, as I understand it from the evidence now, they actually get treated as well as anyone else, but they don't get into the process quickly enough. So that doesn't actually answer the question at all.
We're not going to resolve it, I don't think, but the issue has been the Sally.
I was going to say that is a specific issue we could look at as part of our policy review and update of the evidence. So why has that occurred? Is there any evidence about why there's a diminishing gap in deaths from cardiovascular disease? So that's an interesting point we'll take up.
Good. Mark MacDonald.
Thank you, Convener. This might be a little bit of a brain dump, so we'll see how it goes. I think the point that Bob Doris mentioned earlier about mitigation ties in quite well with the point that Mr Liddell was making about the welfare reform stuff. I mean, only last week we saw figures from the DWP itself showing that there's going to be a huge increase in the number of children in poverty simply as a consequence of welfare reform. But I wanted to move on to a few different issues. I think we've spoken about proportionate universalism, and I know that in Dr. McCartney's paper he talked about the dangers in reducing some universal provisions that are available, and I guess we could have the debate about universality and the benefits it has. But I think the theme that I'm picking up is that there's a bedrock of things that we apply on a universal basis, that we should build on that, and then on top of that we need to basically build a targeted approach where we do more in some of these communities beyond that bedrock of universalism. So I don't think that in terms of when we're talking about this, the targeting and universalism, I don't think there's the clash that one might assume would arise. But I wonder about the notion of it that I always feel like there's a cycle of self-perpetuation goes on, in that we always talk about deprived communities. I know it sounds a bit fluffy in that respect, but we always label communities as deprived or hard to reach. And I remember when I was the vice convener of housing in Aberdeen City Council, the horror at the fact that we were labelling areas as less desirable areas when it came to areas for people to get a council house. You know, imagine the stigma that's attached to that. And I think it does have a detrimental impact on the sort of the self-worth of the individuals, and maybe in some respects that contributes in some way, some small way, to the inequality, simply through that sort of mental degradation that can come as a feeling of, you know, I live in a deprived area, I live in an area that nobody wants to live in, and that kind of thing. And I guess the other point is around the resource transfer that is going to be needed, and how we message that, because, you know, we as politicians, I said it at the last meeting, you know, we're spectacularly bad in politics and always have been at doing the long term well, in the sense that, you know, if we tell people that we're going to shift this money now, but you're going to have to wait to see the benefits of it, you know, it's a hard sell. What's also a hard sell is to those communities or to those groups who we're taking the money from in order to do the targeting. I remember speaking to a senior police officer who said that he goes to community council meetings and is asked for an hour about crime when it's one of the lowest crime communities in the whole of Scotland. Yet at the same time, you know, there are communities out there where he really needs to be targeting his resources, and I guess the same would be true across all sectors. So it's how we get that message across that we need to be much more intelligent, I suppose, in the way that we target, even though there is the likelihood that those people who are not the ones who are being targeted are going to be the ones who might have a bit of a kickback at that. So any advice that could be offered helpfully from the professionals would be appreciated.
I think Mark MacDonald makes a number of good points there. The dangers, to just touch on the universalism point first of all, the dangers of undermining universal public services are multiple. So if you have services which are not seen to be for everyone, then people start to ask questions about, well, why should I pay my tax towards this? And they become poor services for poor people and stigmatised. However, you're also correct that just a flat level of service can often exacerbate inequalities, as we've talked about here. And so we have to provide equitable services, so provide them for everybody but according to need, and that's a real challenge. And I think one of the ways you can sell that, in a sense, is to go back to a point that Professor Tannehill made earlier on, where she talked about the evidence that emerged from Richard Wilkinson and Kate Pickett's work on the spirit level, where more equitable societies do better on a whole range of outcomes, irrespective of their mean level of income. So if you take Japan or the Scandinavian countries, which are more equal in most measures, their outcomes across crime, health, housing, even their environmental performance are all much, much better than more inequitable countries such as the UK and the USA. And so I think there's a sell, if you like, for all people in Scotland, that if we had a more equal society, not only would the poorest groups do best, but the more affluent groups would also do better. And another thing that we could perhaps reflect upon, and I've fallen into this trap myself when I've produced a railway map showing the difference in life expectancy across Glasgow. And it showed Brigton in the east end of Glasgow as having a particularly low life expectancy. And of course what happened was the journalist immediately got on the train, went to Brigton and said, so how does it feel to live in this really rotten area? And we were all tearing our hair out, because that's exactly the kind of stigmatisation that we didn't want to happen. But then we can't sit in silence when that kind of inequality exists. So there's a real juggling act for us about whether we highlight problems, but with that danger of stigmatising people. And one way around that is to talk not about deprived communities or the poor, but it's to talk about the gradient across all of society, because it's not just everybody's doing fine except some subgroup of the population. Actually, as you progress across any ranking of the population, people do progressively better or worse, depending on which way you're looking at it. And so inequalities affects everybody. It's not just the people at the very bottom, and a more equitable society benefits everybody.
I think this is a job for politicians. Inequalities is not a task for technocrats or people to manage on society's behalf with additional services in addition to the mainstream. The mainstream is the message, really. And I think that it's basically social solidarity, and it has to be reinvented because it's disappearing right, left and centre. England's a good example of not to copy, I think, and it may be that the current politics of Scotland allows us to reinvent solidarity, but a key message is that it's not a free good. Everyone needs to be involved, and there's a subscription for everybody. And I think people have lost the idea that they're actually subscribing to a universal system in which they may put in more than they get out. And the challenge is to sell a feeling of satisfaction and relief that you're putting more in than you get out. I think if we go down a consumerist view where people are only concerned with what they get out of services, I think that's a dangerous, that'll be the end of universal approaches, I think. But I think that would be my conclusion, that there's a task for politicians to sell universality as something that involves everybody, and there is a subscription fee that goes with it, and you can't talk about it unless you pay the subscription.
Anyone else?
I think the only thing I can add to this is this concept of co-production. I mean, I completely agree. I think it's interesting to come in at this stage with these issues of labelling and the language we use and so on. And there's no doubt that one of the lived experiences of inequality is that people feel they're objectified rather than treated as people. The language used about them is not human language, and they don't have a say. So decisions are made about them that they don't have a say in. And I think that we really, across everything we do, need to get much better at making sure that we're hearing the voices and involving people who are at the lower end of the socioeconomic spectrum and are the ones who are experiencing the worst health. And we just don't do that well enough in Scotland.
We don't allow sufficient time for it to happen. I mean, the original paper on co-production in a health context, because there were previous papers in other contexts, but in a health context came from a seminar with Julian Tudor-Hart in our department in Glasgow in 1994. And his key phrase was initially face-to-face, eventually side-by-side. And that's quite a journey. You know, a lot of the self-management and self-help initiatives rather assume that people can jump to it, but actually in deprived areas it's a long journey, and there needs to be investment in that journey. But co-production is very much the destination.
Thank you. I think just one thing I would want to make clear, because I have in the past had a comment I've made at committee taken wildly out of context. You know, I'm not suggesting that if we stop calling deprived communities, that everything will suddenly get better. I'm simply making the point that, you know, if we have things like, for example, labelling an area as a less desirable area for somewhere to live, it does build an impression among the people who live there. But I think Graham Watt makes another interesting point about messaging, which is that there is I think that the welfare reform agenda, for example, and other reforms that are happening at a pan-UK level are having an impact in terms of messaging around the point that Graham Watt was making about the breakup of social solidarity, the notion that you now have people who will make a point along the lines of why should I pay my taxes too, and then it will be to, you know, to sustain people who are on benefits, for example, or to deliver a better service to a certain section of the community. And I think we do run that risk, and I guess Graham Watt is absolutely right that the onus is on us as politicians to try and counter those arguments, to try and develop a counter narrative to that. So I guess it's a challenge he's thrown our way, and I guess we'll have to ensure that we're up to the task.
No others on that. Gil, is it? Gil?
Thanks very much. Dave Liddell touched on the subject, and that's welfare reform. This committee was informed by a senior Westminster civil servant that the intention was to take 2.6 billion out of the Scottish economy through welfare reform, and that's going to touch on housing, and it's going to particularly touch on people who are poor, including the working poor. And I just wondered what the panel's view was on that, and how it's going to impact on the services that are provided, and more apt, I would think, is this Parliament and this government and the resource we've got available, is it up to the job? Can it possibly mitigate against that type of attack on the welfare state in Scotland?
We had a meeting last week of 30 deep end GPs with civil servants from the DWP in London discussing the ESA reforms and the imminent PIP reforms. And it built on a report that we did last year reflecting on 1 week's experience of patients and practitioners of the fallout, particularly from the ESA assessments. And there is an enormous fallout. A GP in Parkhead says that he spends 20% of his time now dealing with the follow-on of these initial assessments. And there are problems in terms of the dysfunctional nature and the lack of understanding of the new system that's been set up in terms of the initial assessment and the appeal. And that often works to patients' disadvantage. But even when that is ironed out, as it inevitably will be as people accommodate to a new system, there is a brutality about the forms in the sense that they are essentially technocratic, trying to impose a very supposedly objective assessment of capability to work, really irrespective of the consequences of that decision. And what came across clear from the meeting with 30 GPs from different practices was that they were as concerned with the consequences of the decision as the decision, which has a huge mental health burden on individuals trying to cope with conditions already, with destitution a real prospect as a consequence of this supposedly objective measure. So I think the GPs were actually just against the system in terms of what it was trying to do for their patients, because ultimately they are advocates for their patients. But we did get advice, which I'm sure you've had too, that the new PIPs will, as night follow day, will reduce the number of people getting DLA and reduce the amount of DLA that other people get, whilst a minority will get more DLA or PIP. And that is going to have huge consequences. Our impression is that in trying to reset the parameters as to who gets benefit and who doesn't, it's been done in rather a crude way, but rather a screening way, which has resulted in a whole lot of judgments which have been inaccurate and unjustifiable and redeemed by appeal. But the appeal process is lengthy. It requires personal resources that many people don't have. Now, I've been helping my daughter appeal against an ESA decision, and it just makes me wonder what it must be like when you don't have professional help to negotiate the system. It gets back to the question of solidarity and universal support and what people are prepared to pay for. The system has crudely thrown out put the ball into the court of patients saying appeal, and if you merit the benefit, you'll get it. But that's a very costly way of going about it in terms of the implications for the mental health of the patients and the services that have to gather the information for the appeal. So there's a crudity about it, which is actually quite unpleasant. And if the system was unearthing lots of people who were getting benefits that they didn't deserve, then maybe there would be a justification for it. But the common experience is that those types of examples, celebrated in certain types of media, are actually uncommon. And you never iron that out entirely. And I think if we have a universal system, we have to tolerate a bit of inaccuracy in assessment in order to avoid the harm that's been done by trying to objectify assessments of individual cases. Because usually, so I'm going on a bit, Chairman, but the tick box approach, which I've seen in operation, at face value, it looks thorough, it looks conscientious, it's very polite, but at the end of the day, it fails to understand the complexity of disability at an individual level. And I think one of the good things about the PIP developments that are coming is that the people doing the assessments will be OTs and physios, not doctors, because they have a much better assessment of the extent of people's ability to live independently. Sorry, I've gone too long.
It's asked a really important question, and clearly people in our world who have got a responsibility for public health are very, very worried about the impact of the so-called welfare reforms on the health of the Scottish population. And the kind of figure you've quoted of 2.6 billion, if that's the case, then clearly that's going to have a massive impact on income inequalities and the living standards of probably our most poor communities. I think there's two sort of additional things I would just raise here. First of all, the aim of the welfare reforms in its own terms was to move more people into employment. But if you look at job availability in Scotland and where people are looking for work, there are nowhere near enough jobs to go round, and where the greatest number of unemployed are is where the fewest jobs are also. And we'll be publishing a report in the next couple of months which will show that and show the trends in that. And in truth, there's not been a time in the last 3 or 4 years where there has been enough jobs to go round. And so it's very unlikely that these welfare reforms will move people into work, because there simply isn't the work there for them to go to, even if they were able and fit and able to do so. The second point I would just make is that it's really, really difficult for us to evaluate the independent impact of welfare changes on health. And the principal reason for that is that we've been unable to get a hold of DWP data to facilitate that evaluation. There's a number of barriers Scottish researchers in particular face to getting individualised records and getting them linked to health records in Scotland. And so it's very, very difficult indeed for us to be able to say anything conclusive about the impact of welfare change on health outcomes. We will be producing a sort of baseline report for the May meeting of the Health Inequalities Task Force, which will outline in very high level and broad terms what the impacts might be, but it's very restricted because we've got the impacts of recession coinciding with impacts of welfare change, and we'll have no individual level data to be able to explore those changes. However, the work that Graham has described, which is more qualitative in nature, I think makes the point very well that the feeling we're getting from services at the moment is that the impacts are fairly profound and fairly negative on health.
Is that you? I wondered if Poverty Alliance would like to make a contribution.
Well, I mean, I think really just not to repeat what other people have said, but clearly, yeah, the impact already is devastating. And as you say, in terms of that amount of money coming out of the people's pockets will be hugely more damaging than what we've seen already. So I think across a whole range of measures, including a range of health measures, particularly mental health, but not exclusively so. And of course, as you describe, in terms of actually trying to mitigate against that is going to be extremely difficult. Obviously, some of those issues around particularly payment in arrears as well as another big issue as part of that, not just in terms of reduced income, but also obviously being paid in that way, which is supposed to normalise people with the people in employment, and I think it will have a hugely negative effect as well. And obviously there are, I'm aware of credit unions and others trying to mitigate some of that, but obviously it's going to be very limited in terms of the potential to do that.
Just one quick question or observation from Dr. McCartney. He was saying difficulties with the DWP. Is this including the Scottish Government? Is that a route that's been channeled, the questions to try and ascertain the information that's I would have thought would be automatic, to be quite frank with you, rather than you having to ask.
I don't know if Sally wants to offer a comment on this as well, but I previously worked at the MRC unit that Sally is the director of, and we spent a long time engaging with the DWP at that point to try and gain access to their data to allow follow-up to measure the impact of welfare changes on health. And they have a preferred researcher mechanism whereby they ask the research questions and they commission people out to do that research, and they won't release their data beyond that. And the Scottish Government, as I understand it, have been trying very hard also to gain access to individual level data to facilitate that. You can get the aggregate data, so you can find out how many people get job seekers allowance or how many people get ESA or such like, but that's not very helpful if you're trying to look at individual outcomes, because what we'd really like to do is link that to health records, or at least have a clear idea on an individual basis what the outcomes are for those individuals.
Lynette?
I just wanted briefly to touch on unemployment, which has obviously been mentioned several times. Now, I'm from Aberdeen, which is overall a very prosperous city, but with its own pockets of poorer areas, deprived areas. But within Aberdeen, we have a very low unemployment. And that itself is causing problems. I mean, the local paper today on its front page has the issue of people waiting far too long to get care at home because of the difficulty of recruiting home carers, because they can get better pay, clearly, in oil-related industry and so on. So Aberdeen's suffering from a lack of people to do well, services are beginning to suffer because of lack of people to do them. Is there any merit at all in looking at some sort of incentivization of workforce mobility so that people could be encouraged to move from some of the more deprived areas where there aren't jobs to areas like Aberdeen, and I dare say there are more, where there are jobs, but it's very, very difficult to recruit people to work in. No takers. Pardon?
Where would people stay in Aberdeen?
Well, that is an issue as well. I do accept that accommodations are probably more expensive in Aberdeen.
I could maybe offer a general point that one of the things we also see across the UK is spatial inequalities, and you get often a kind of poles of economic growth and therefore employment. And the southeast of England is a classic example of that, and where that income and wealth and employment isn't spread across the country, you end up with these spatial inequalities as well as inequalities by social class or poverty, what have you. So I think the way in which development is spread across the country is something that might be worth reflecting on as well. We know that our most deprived areas are concentrated in the west of Scotland and in central Scotland, whereas we have some more affluent areas round about. And I think one of the problems actually of that inequality and affluence across Scotland might be the problem you describe.
Yes, I mean, I'm sure as you asked the question, we were all sitting here thinking, well, that would mean people moving their families and where would, I mean, all the things. So I mean, clearly there are all those issues, but people, I think, do move for jobs. We know that, and I think the nature of work is changing so much that people recognise mobility for employment is going to become much more part and parcel of what people do. So at one level, what you're suggesting clearly isn't against a wider trend at all. One of the things I welcome about this current focus, though, is that we know that the young working age group is the section in society where health inequalities are the widest. And it's also the part of the Scottish population where health trends have improved the least. So it's really helpful collectively to have a focus on that group. I know the CMO always pushes early years, and we would support him in that. But the other group, that really is driving Scotland's health trends are the young working age, and that is significantly to do with the quality of work, access to work, and all these exclusion issues we've talked about. It's not simply poverty, it's the way people treat you. when you're in poverty and the things you're excluded from in that way. And work is such an important route into that. So, you know, whilst, as I say, my initial reaction was, gosh, there's all sorts of problems with this, I think we have to also recognise the potential of the sorts of approach and that redistribution within Scotland of employment and opportunity.
Time for a wee plug. I think we recommend the committee's report into the regulation of older care, where we look at all of that quite extensively, about how we pay and award that workforce, how we regulate it, how we contract and commission services. All of that are big inequalities issues. How we treat the people who care for our elderly and vulnerable is. You know, I think the example that was used, that you can get more money handing out leaflets for the Edinburgh Festival than you can working in a care facility looking after old and vulnerable. Maybe that goes beyond health, of course, but that was a plug for the committee's report. Good read. I think I've got all the questions, I think, from committee members at this point. And could I thank you all for your attendance here and give you one final opportunity to put on record anything you feel that we didn't pick up on today, or something you came to basically, it was important for you to leave a message with us. I'll give you that opportunity now. And certainly we would encourage you to observe our inquiry and take an interest in that. Not just a passive interest, but we would welcome your ongoing comments about evidence and that may be presented that you strongly agree with, strongly disagree with, or even have minor points. We would welcome that input throughout the inquiry, because we discuss all of that when we come to our final report. Is there anyone at this stage who wish to put anything else on the record? Sally?
I was just really picking up on your earlier point, Convener, about do other sectors take notice of inequality. So one of the roles of this committee might be, if it's accepted that things like education, employment, housing, etc. influence inequalities in health, is does this committee have a role in its inquiry of engaging those other sectors of government, both central and local government? Would that be a topic for its inquiry?
I think we're limited as a committee, but obviously, you know, the evidence that we've heard only in 2 sessions, you know, would likely lead us to some conclusions that others maybe need to look at this. I mean, I can't preempt it, but given the evidence that we've had today and in our first evidence session, you know, there is much more involved in this issue than just simply health. And you know, I think we take your point, Mr. Liddell.
It was just maybe to pick up. I think you know, Jerry's has made a number of points in relation to this, but I suppose, you know, just to suggest that you unpick all of those issues around the asset-based approaches and looking at that and the risks, I suppose, around that individualising health problems, and I suppose the risk with that obviously is avoiding the focus on the more fundamental causes of health inequality. And as I say, we'd urge the committee to explore that issue in detail. Maybe if I can just quickly pick up on a couple of other points around, and I suppose it was just really alluded to in terms of the notions of moving resources more, if you like, upstream as being the phrase often used in terms of the early intervention. And our view is that you know, isn't about just the early years, the 0 to 3, is actually it can be achieved, you know, across the spectrum of people's whole lives, and I think that's an important point to keep in mind. And thirdly, I suppose it was just going back to the issue of employment, and I suppose the question of whether there's any lessons to be learned. I'm sure there is, around all the regeneration programs that have delivered to deprived communities over the last 20, 30 years. And particularly, I suppose, the focus on, if you like, the bricks and mortar rather than actually the people within those communities, and the need to actually learn some lessons around that. And again, I go back to my initial point around the community benefit clauses and looking at actually ways in which those programs can actually engage much more with the communities that they're seeking to develop and improve, and actually look at, you know, if you like, more bottom-up engagement with those communities in terms of how best to deal with those programs, rather than focusing narrowly, as I said, on the bricks and mortar. Thanks.
Anyone else? At that point, it just remains for me to thank you all once again for your time and your evidence provided this morning. Thank you all. Bye. Suspend at this point. And